Chapter 6, Knee and Calf, Massive Patellar Tendinosis, and Total Knee Arthroplasty Exposure Planning. Conflicts of interest. I'm a stockholder with Sonics Health and co-editor of a textbook on ultrasound. Case report is a 49-year-old woman who's referred for a second opinion because even at this young age it looked like she might need a total knee arthroplasty. She's undergone 2 previous arthroscopies which showed loss of articular cartilage in the lateral compartment. She continues to have pain in spite of NSAIDs and injections. Of particular interest was her MRI. On the screen now you see the MRI before the first and second arthroscopies. And I want to draw your attention to the outline of the patellar tendon, which is a nice, neat, straight, dark structure. On the repeat MRI, we see that the tendon is increased in diameter and there is increased water content in the center. If this was a spinal cord, you would call it a syrinx. On ultrasound, we see that the fibers seem to be intact, but that there's an increase in swelling and therefore a decrease in echogenicity. So what we see is that she has increasing pain and still no response from all the conservative measures. Our assumption is that there must have been a vascular accident causing an ischemic event in the tendon. The previous surgeries were not particularly traumatic, so we're going to go ahead with the total knee and ask yourself, how do you plan for the total knee arthroplasty? So we decided to look to see what was the remaining blood supply of the patellar tendon, and we see that it seems to be on a single or double vascular axis. On the left you see a larger than normal artery coming up the lateral side and the back side of the patellar tendon. This is a short axis view. On the right side of the screen we see a long axis view of the recurrent anterior tibial artery. So in planning for the total knee, we make a standard medial incision, but we're trying to protect the lateral inferior genicular artery and the recurrent anterior tibial artery. We also saved more fat pad than we normally do. The tibial component was set a little bit medial to protect the arteries, and this resulted in a thin shell of bone on the lateral tibia. Her early results from the surgery were excellent, but at about 4 months she had sudden onset of a new pain, and on ultrasound we can see that lateral bone fragment has become detached, and this is probably the source of pain. So we decided to remove that piece of bone arthroscopically. In this lateral compartment you really can't work and see at the same time, so we're using the ultrasound to direct our instrument to the bone fragment which is embedded in scar, which makes it difficult to see on arthroscopy. Here's the polyethylene, here's the medial tibial plate, and this is the bevel of the femur. Here we can see on the left the instrument approaching the bony fragment, and on the right we see the arthroscopic view, and we can see the grasper pulling the bone fragment which had been exposed with a shaver. Two years after this surgery, we got a follow-up view on her, and we can see that the tendon is thinner, but it's still based on that same artery. On the left, we see the 2-year result, and it is thinner but not totally normal. And on the right, we can see what we had when we started treating her, the greatly swollen tendon. So in summary, ultrasound aids in the diagnosis of soft tissue abnormalities. It helps with planning surgical approaches with respect to vascularity. If you look in the children's chapter, and particularly the spine section, you can see ultrasound being used to design flaps for closing myelomeningocele. And ultrasound is useful in following the post-op progress of a soft tissue abnormality. Thank you for your attention. For more interesting cases, consult our text.